Hi, my name is Brodie McLeod and I'm a shit YouTube vlogger and also a psychiatric inpatient and potentially wielder of one of the most valuable sets of inventions in the last 100 years, but I'll leave that for another day. I just saw an article in the Spectator, my newsfeed, about kind of the struggle the NHS is facing under increased mental health demand, and I've been kept in a place of safety by the police for like 45 hours waiting for a bed to be allocated. I thought bed allocation was simple, like spreadsheet, square peg in a square hole, but it's not. It's actually really complicated if you read the policies for NHS. NHS incidentally keep their policies all online. So if you're an inpatient or if you're somebody who knows somebody who's in hospital and you think they might have suffered a grievance or a breach of policy, guidance, legislation, law, you can go on the NHS and you can download all their policies on everything and you know where you stand. Private healthcare providers don't do that. They just, they can tell you something against the rules is something that's against the rules, and it's just bollocks. So it might be, you haven't got anyone ever adjudicating it. And I've negotiated a really kind of lengthy set of complaints. I've had to complain about 10 times since I've been here about all sorts of different things, and some of them I've just like amicably dropped because I don't want to endanger somebody's career over something like a defaced ID badge or a kind of like minor medication error, or like, I don't know, there are some things which are going to just stand in the way of people who do their level best trying to save people's lives when they're having the hardest time they've ever had. I think there's a lot of value in psychiatry, but it does need to be overhauled, and it does need to be cleansed of the visceral corruption which plagues it at the moment. More on that maybe another time. Anyway, I sort of had a chat with Gemini and was like, looked at a few proposals, and if you like, you might not have ever heard about, unless you've been sectioned or you know somebody who's been sectioned under the Mental Health Act. There's a few companies. There's one called Cygnet, Cygnet, like Baby Swan. There's one called Elysium, and there's another one called The Priory. Between these three companies, the NHS dishes out phenomenal sums of money. And if you like, their profit margin, which is obviously down to good accounting, but if you look at their public reports, is just a pure metric for loss, and ultimately so is their turnover. Like if things were nationalised, I don't want to live in some sort of socialist utopia. I'm kind of like a left-leaning socialist basically, but there is toothpaste all over my fucking t-shirt. What a gent I am. There's an interesting dialect and dialogue between public and private sector funding. A lot of people were anti-Obamacare. You've got that kind of laissez-faire thing as well. Always say for taking the piss out of Bupa. Bupa, for those who can afford it. Like, look, basically most people would go to Bupa if they could afford it rather than the NHS, but most people can't afford it, so there's a bit of a paywall there. But yeah, like I think it's a bit ridiculous that we spend so much outsourcing mental health, and with the strain on the NHS, there couldn't be a more of the moment kind of relevant sort of maybe half an hour or 45 minutes, however long it takes me to read this document, to have a little think about it and maybe write to your MP or tell your mate who works in a senior NHS office, or just tell somebody who has got mental illness and who might face a section or has been sectioned. I've got blood all over my face from having just had a shave. That's fucking disgusting, isn't it? Anyway, I'll read the research paper. You can listen to me read it. You know the gig. And feed me back. Like, let me know. Tell me in the comments. Tell me in the message. Tell me in a tweet. Message me on Facebook. Do whatever if you've got any ideas. You think my sort of take on it is a bit shit, or you don't agree with the kind of situation as is, and you've got an opinion. I'd love to hear it. Most of these videos get like 10 or 15 views, and nobody really watches them. But for those who do, mostly my enemies. But for those who do watch them with a critical eye or a kind of an altruistic air about them. It's great. I'm not the best presenter in the world, not particularly photogenic, and I don't have a large audience, but it's a great cause and a very important topic. So without spending any much longer, let's open the research paper, which is entitled "The Economics of Empathy, a journalistic inquiry into repurposing the high street to save NHS mental health services." So the structural integrity of the United Kingdom's National Health Service is frequently tested by winter pressures, pandemic backlogs and funding deficits, but perhaps nowhere is the system strain more visible and devastating than in the realm of mental health care. The true scale of this crisis cannot be measured solely by psychiatric waiting lists. It's most acutely understood by witnessing how other vital public services are buckling under the weight of inadequate mental health infrastructure. As observed in an incisive piece for The Spectator by political journalist Isabel Hardman, the cascading effects of a broken psychiatric system have turned emergency departments and police forces into providers of last resort. Hardman highlights in the Spectator article this is a profoundly distressing reality that accident and emergency A&E departments have become de facto waiting rooms for individuals in severe psychiatric distress, despite being fundamentally inappropriate, chaotic environments that are entirely unconducive to therapeutic care. The statistics underpinning Hardman's analysis paint a grim picture of systemic failure. According to data from the Health Services Safety Investigations Body, HSSIB, mental health patients are twice as likely as other patients to remain stranded in A&E for more than 12 hours. Like I said, I've done like a 48-hour visit. I've been at a place of safety so long, they had to come and furnish me with a document from a ward clerk called an unauthorised deprivation of liberty, because they still hadn't found me a bed. I've been there, done that, got the t-shirt. Even more alarming is the revelation of nearly 25% of all patients enduring agonising waits of over 72 hours in emergency departments are there for mental health related reasons. So these individuals are trapped in a legal and medical limbo. A&E staff lack the legal authority to prevent patients from leaving the department before they're properly assessed. So they, even if they've been put there by family, they might not be wanting to be sectioned and locked up. Do you know what I mean? Some people are very reluctant to that, even when they are ill. And even when clinicians believe they're too unwell to be on their own, they have to stay there. This places healthcare professionals in an impossible position of choosing what the HSSIB terms the least harmful way to break the law, simply to keep vulnerable human beings safe. Simultaneously, law enforcement agencies are increasingly functioning as frontline mental health responders, draining resources away from the primary crime and justice matters. So in Scotland alone, Police Scotland Chief Constable Joe Farrell reported that officers are called to approximately 700 mental health related incidents a day. These interventions frequently consume an officer's entire shift, involving waits of up to 8 hours in hospital corridors, attempting to hand over care to an overstretched medical team. This dynamic represents a profound misallocation of state resources, creating a scenario where police and emergency doctors cannot treat acute physical trauma, people that have got bad injuries, all because the psychiatric safety net has eroded. So the bottleneck is the downstream consequence of a severe historical deficit in the NHS's psychiatric inpatient capacity. Over the past few decades, a policy of deinstitutionalisation coupled with chronic underfunding has seen a number of NHS mental health beds in England plummet by nearly 3/4, dropping from approximately 67,000 back in the 80s to only 18,000 in 2019. To bridge this enormous gap between rising clinical demand and shrinking public capacity, the NHS has increasingly relied on the independent and private sectors. By the final quarter of 24-25 financial year, out of the total mental health bed capacity in England, approximately 29%, equating to just over almost 7,200 beds, was provided by the independent sector. Now, while this outsourcing has undeniably provided vital surge capacity and kept the system afloat, it comes at an exorbitant and arguably sustainable financial cost to the taxpayer. Recent analyses indicate that private firms providing services to NHS generated an astonishing 1.6 billion in profits over a 2-year period, fueled by public contracts worth 12 billion. The debate over the return on investment and the fundamental financial sense of bringing these mental health services back in-house into the domestic infrastructure of the UK is therefore of paramount public interest. This is exponentially increasing mental health crises, and we're in a system of finite resources, and we're giving loads of money away to private sector companies who just drive fucking AMG Mercedes and live in beautiful big houses because they're fucking shareholders or equity holders or employees of six-figure salary private mental hospitals, which is always a metric for loss for the NHS. However, it goes on to say a simplistic demand to instantly renationalise all psychiatric beds is not a watertight solution. The NHS lacks the immediate capital required to build the dozens of highly specialised, secure mega hospitals that would be needed to replace the private sector's footprint. Therefore, a more pragmatic, innovative and highly effective alternative is required. This report explores the economic and clinical pragmatism of overhauling NHS direct mental health care. It critically evaluates the profit margins and financial engineering of private subcontractors, exposes the limitations of traditional hospital building programs, and ultimately proposes an incredibly viable solution: the schematic phased rollout of community-based crisis houses converted from low-end vacant high street commercial properties. This model promises not only to save countless lives through enhanced trauma-informed care, but also to endow the NHS with vital funds to massively expand its human resources, and at a time when financial leniency is nowhere left on the horizon. So the financial hemorrhage, the architecture of outsourced care. To fully grasp the motivation for a radical overhaul of the NHS's provision, one must dissect the current economic model of outsourced care, just as